I agree that culture negative is very more in number, either because you are not able to culture it or the organisms are getting smarter. We'll talk about that evidence-based medicine. It's not working, not moving. Hello, it is not moving. It moved. Till now, we are dependent on a very important real path-breaking study called endophthalmitis vitrectomy study, EVS in short. It was published in 1999 Archives of Ophthalmology. Now it is renamed as JAMA Ophthalmology. It talked about this is a typical 2x2 study where it said that should or should not use vitreous biopsy or vitrectomy immediately, and should or should not use systemic antibiotics. And he gave two important information to us. One, that vitrectomy required only when visual acuity is poor. Poor, the defined, even defined hand motions or loss, like light perceptions or less. Also told that systemic antibiotics do not add benefit to the entire stuff. Also remember that recruitment-wise, EVS recruited enough eyes where the cornea was clear enough to visualize. Actually, in practice, as we saw some of my actual practice in my India or in my presentations, that doesn't always happen. The cornea is always clear to do a vitrectomy, because today we can do an endoscopic vitrectomy if the cornea is not clear. Legacy-wise, EVS had a huge legacy. For the first time in the world, they put a level 1 evidence of managing post-cataract acute bacterial endophthalmitis because they did not have any fungi. And two, it reduced economically both for the provider like us and the patient, because reduced hospitalization, only injections, don't have to stay in hospital and don't have to have a systemic therapy. But within 10 years of this publication, many publications start appearing that questioning is the EVS the current thing. It started with the Frank Kuhn, that endophthalmitis vitrectomy study is relevant after 10 years of his publication. And finally, year for last published from United States, asked EVS guidelines still valid. In between, Grabowski from Poland and we from India keep on questioning that should EVS guidelines be relooked. Why should we relook is, one, between 1990 when EVS started, 1990 to 1994, technology of vitrectomy has improved significantly from large gauge to smaller gauge and the better fluidics and lighting condition. Microbiology, as Jovita told, has already increased tremendously both technique and technology-wise, and also Ajay told about the gram-negative infection. And third is that this also Jovita showed that resistance of commonly given antibiotic, particularly ceftazidime, has increased tremendously. We also saw that the spectrum of infection reported either in USA EVS or Europe ESCRS were different than India. In India particularly, we saw that gram-positive cocci are much less, 53% compared to 90+% in Europe or America. Gram-negative bacillus much higher, 26% compared to 6% in EVS, and we have a fungal infection whether you like it or not. Not only we but also came from China and Singapore, that the spectrum of infections are different, which means that your management has to be different than what was always proposed by EVS in 1995. So we have three important research questions. Should the presenting visual acuity be the sole criterion for choosing empiric treatment? Because you can't get a culture report immediately, you have to start the empiric treatment whether you like it or not. Two, shouldn't new technology be added to the lab workup, like Jabita told about, or Ajay told about PCR and Sanger sequencing, next-gen sequencing. And third, because of growing antibiotic resistance, particularly for gram-negative bacilli, so there is alternative to ceftazidime. We answered all these questions by, one, we tried inflammation score instead of visual acuity, which I presented first time. And two, we also use Sanger and next-gen sequencing for microbiology work. And three, we choose two antibiotics, imipenem and colistin as alternative to ceftazidime, and design this large study. It's registered on the clinical trial register of India. We just December this year we finished, last year we finished. We are now in the stage of analyzing the data. As you also, when you said inflammation score, we revalidated it, even though we used it in 1990 in our DEXA endophthalmitis study. And then we choose these are the drug combination which are used for EMS. For particularly fungal infection, we had choice between amphotericin B or voriconazole, natamycin topical, and systemic itraconazole. In variants to the EVS, we always use intravitreal dexamethasone because we found very useful for bacterial infection in India. And two, use the oral ciprofloxacin 750 milligram twice a day for 5 to 7 days because Cipro has got a good vitreous penetration compared to then used vancomycin, amic acid, and ceftazidime. This was done a multi-study randomized clinical trial in 3 adjoining states of India, Telangana, Andhra Pradesh, and Orissa. 3 states, 4 large tertiary centers and 20 secondary centers. 432 patients recruited. After 21 patients did not have a regular follow-up at least for 3 months to exclude them. Ultimately, total 411 patients, and everything is shown there. By B scan, which Ajay showed very beautifully, 99% had some kind of echoes. Some kind of echoes, and 53% had no glow of the vision. That means this all guys was called so-called severe. At the same time, 1.7% patients also had a vision of visibility of third order vessels. Visual outcome after treatment, as we explained in our randomized clinical trial protocol, 1/4 of them, 25% had a good vision, defined at 20/40 or more. Half of them had a navigational vision, and 2/3 of them had a ambulatory vision. At the same time, we could not save 1/10 of the patients. We also saw that by logMAR vision keep on improving after treatment from 2.2 to logMAR, which is that means very bad external vision to improving to 1.29. Also, inflammation score reduced from 14.41 average to mean to 2. As Jovita has already shown this, that culture positive was less, but then NGS positive was 61%, fungi were 12% in our patients. And this was repeating what Jovita told, that all culture negative but not necessarily organism negative. So we defined a new term called a micro negative, which is culture, micro positivity culture plus sequencing, or micro negative culture plus sequencing. It was all the negative bacilli organisms were actually positive bacteria or the fungi. We also found in the culturable organism, 39 or 40% of them had multi-drug resistance. Most of them were gram-negative bacilli. This is already shown that Vanco was better than other drugs. Similarly, colistin was better than other drugs for gram-negative organisms. We also found, interestingly, that those who are resistant to those gram-negative bacilli resistant to colistin were sensitive to ceftazidime. Actually, that raises an important question that we are not able to identify proper or do not have an immediate microbiology facility, so to combine ceftazidime vancomycin so that the patient doesn't have to require second injections or through. Colistin prepared this way, 1,000 units. It comes in a 100,000, 10 lakh while then you dilute 2 times to get it to 100,000 international units. This is what Jovita is talking about, very important for me. CDC says that both vancomycin and colistin are the last drug. Vancomycin for gram-positive cocci, colistin for gram-negative bacilli. But this is for systemic therapy. Look at that therapy part. Intravitreally, you give 2 gram dose every day for vancomycin for at least for 6-7 days, and dose vancomycin is 1/2000, most probably 1 or 2 times, with half-life of something like 3 days for vancomycin. Colistin half-life is very short, 3.5 hours. We give 1/9000th required for a per day injections of colistin. To my mind, because endophthalmitis is a serious disease, empiric treatment is standard of care right now. Can't wait for the culture, because by the time culture report comes, your eye might be lost. And true intravitreal half-life is so low that most probably it may not cause any systemic